All right. Okay. All right. So the article that I chose this month came from Dr. Merlin and group on the long-term opioid therapy trajectories and overdose in patients with and without cancer. And this was the British Medical Journal of Oncology this year. And so our learning objectives today is number one, hopefully you'll be able to describe the different trajectories of long-term opioid therapy, be able to acknowledge what the impact is of having a cancer diagnosis is in the opioid overdose risk. And then hopefully also by the end of this hour, you will apply universal precautions for opioid prescribing. So just some background as to why they did this study is basically, as I said, there's a lot of cancer pain. Cancer pain is prevalent. It's about moderate to severe pain is reported by about over a third of patients who have cancer pain. If they have advanced metastatic cancer, over 60%, almost 70% of patients report cancer pain, and that being moderate or severe. Even for those who are cured of cancer, over a third do report having pain afterwards, and over 50% during the course of treatment. The American Society of Oncology does recommend using opioids. They are still the cornerstone and mainstay of cancer pain treatment for anyone who reports moderate to severe cancer pain. And the National Survey of Drug Use, which is performed annually in people who are in the general population, not in nursing facilities, not in jails, but living out in the community. Survey of adults, of people age 12 and older, found that about 50% of people with a cancer diagnosis within the past year were prescribed an opioid during that year. So lots of cancer pain, lots of opioids prescribed. As far as long-term opioid therapy and the risk of overdose death, as we know from CDC guidance, that there is literature that supports that long-term opioid treatment, so greater than 90 days of consistent opioid prescriptions, at least for patients with chronic non-cancer pain, is associated with a risk of overdose, and that risk increases as the dose goes higher, especially in those who are prescribed greater than 90 milligrams of oral morphine equivalent. And that we do have data even just recently within the past 3 or 4 years, again, of retrospective cohort studies. The two main ones cited in this article as reference were performed out of Kaiser, Colorado, of a database of patients, of about 15,000 patients approximately, who were not in hospice care, were not in nursing homes, and without a cancer diagnosis, and following those patients and seeing if they had at least one opioid overdose events. Most of those opioid overdose events were with people due to prescribed opioids, not due to non-prescribed opioids such as heroin. And they found that this dose-dependent risk of overdose. For those who were tapered and stopped on their opioid therapy and did not get a refill, and they counted that 90 days after the last prescription, it was associated with a 50% reduction in that risk of overdose. To note with this study, though, that they excluded patients who had active or prior diagnosis of cancer. And so Not only is the risk related to just the dose, it was also related to the dose variability. So if there's a variability in the prescriptions during that time of greater than 27 milligrams oral morphine equivalent variation, that was also associated with an increased risk of overdose compared to those who were prescribed a lower dose or had a lower dose variation in their prescriptions over time. And that decreasing the opioid dose did decrease the risk of developing subsequent opioid use disorder compared to those with continued prescriptions and stable dosing. And then also high dose increasing doses was associated with an increased risk of mortality as well as developing opioid use disorder. So the study question is, do these same concerns that we know from the CDC guidance and in all these studies with long-term opioid therapy and the risk of overdose in chronic non-cancer pain, does this apply to patients with cancer? So the study aims was to first identify trajectories of long-term opioid therapy in patients with cancer as well as without cancer. So just reproduce it and add people with cancer, and to assess those associations and trajectories with the risk of overdose. And then considering, okay, now we're also adding people with cancer. And the hypothesis is that we would see the same thing, that there would still be a higher dose and higher dose variability associated with a greater risk of overdose, and then that risk would not differ if they had cancer or not, or stage of cancer. So that's the hypothesis. Just like the other, the background information is, they looked at retrospective chart review, cross-sectional, like a point in time of a population. They looked from 2010 to 2017, and this was in the Veterans Health Administration records. And they defined people of saying, okay, they're eligible for the study because they had 90 consecutive days of opioid prescriptions, so we know that they do have long-term opioid therapy. And they did allow maybe a 30-day gap between fills. If it was longer than that, then they weren't considered to be on long-term opioid therapy. Because they couldn't make a direct association if it was cancer-related pain, and they started opioids for cancer versus having a previous chronic non-cancer related pain and then diagnosed with cancer. They did try to go back as far as if they had a cancer diagnosis as recently as 2004 to the end of the study period, that it was probably cancer-related pain. Or at least, pain related to the cancer treatment. They did exclude people who were on opioids as medication treatment for opioid use disorder. So they excluded the sublingual buprenorphine product, and they excluded those who were not getting prescribed methadone. They also excluded patients who entered in hospice care within 90 days of entry. So if they started long-term opioid therapy and in less than 90 days they were in hospice care, they excluded those. And then those with non-melanoma skin cancers. And then for those who were on long-term opioid therapy and then eventually were admitted to hospice, then they just right-censored that data and just called that censored data, that the event of interest likely happened after the period of study. And then they did a sub-analysis of those with advanced stage cancer, stage 3 or 4, to answer that question. And so how they organize that data is they would look at 30-day periods and find what the median prescribed oral morphine daily dose was. And then they were able to plot that. If the patients were actively engaged in care and they had no prescriptions greater than that time period, then they would set that as a 0 milligram. However, if they were potentially getting opioids prescribed, but it was outside of the VA system, so they couldn't see that. So if it was a non-VA palliative or hospice care, then they just treated that as missing data. And then they would aggregate that and then find these 90-day periods where they could enter what that median dose was in order to group the patients. One thing to note is with this, that because there appeared to be a lower number of prescriptions of greater than 100 milligrams oral morphine equivalent daily, that they didn't separate those out. They just grouped all of those together. So the highest grouping was greater than 100 milligrams. And I'll bring that up later. And so the study event was an overdose event. And so they didn't separate if this was a non-fatal overdose versus a fatal overdose. They did identify, though, that patients who died within the same 90-day period or the very next 90-day period after the overdose event was probably a fatal overdose. Well, they didn't really talk about that much in the study, but they did see that, make that distinction in order to see if the correlation. All right. As far as the demographics, what they looked at other chronic medical conditions, and they looked at the ICD-9 and ICD-10 codes for all the patients that were in the inclusion criteria. So they looked at the co-occurring medical conditions as well as the co-occurring mental health conditions. And then they did also try to make a separation of the change in practice, especially as we were starting to emerge with the 2016 CDC guidance, really calling to action that long-term opioid therapy, and especially high doses, were not evidence-based treatment for chronic non-cancer pain. And so as these changes are starting to emerge within the VA system around 2015, they made a marker for that, and we'll see that data later. And that's when the VA really increased initiatives on non-opioid based pain management, including cognitive behavioral therapy and acupuncture. And so the way that they were able to analyze this is they would put in all that data and use statistical software, and so the statistical software was this Traj procedure that they used, and it's a likelihood-based estimation model. So you were able to put in that data, and that software was able to cluster kind of the trends of what those numbers were to then cluster out those groups. And it did allow for that missing data or the sensor data as well. And so by using that, then they could maybe see what are the groups of the different trajectories. And then the goal was that they went from the time that someone was started on opioid therapy, any time in there between 2010 and 2017, and then following that for 4 years. So that would be 16 groups of like 3 months of like 4 groups out of each year, right? Because it's 90-day periods, and then for 4 years. So there were like 16 90-day periods from the time that each patient could enter the study when they were defined as having long-term opioid therapy. Okay. And this is my attempt to kind of look at the 3 points that they were trying to see would intersect. So they're looking at the different groups of what the starting dose of long-term opioid therapy was, if it started at low dose, less than 30 milligrams, morphine equivalent daily dose, or moderate 30 to 90 or greater than 90. Then they also wanted to look at that dose trajectory. You know, was the dose over time starting to go up? Was it, not change? Was it going down? Or was it, when it was increasing, they also made the distinction between just increasing or increasing kind of exponentially with this. So they called that escalating with quadratic downturn. And then they were also looking at the cross-section with if someone was diagnosed with cancer and if they had those other comorbidities, and then the Charlson a comorbidity index. And so here are the results, or here first are the kind of demographics, sorry. And so of the patients with cancer versus the patients without cancer, you'll see I circled in there which seem to be more prevalent. So those with cancer did seem to have a higher percentage with comorbidities such as COPD, cirrhosis, CHF, compared to those on long-term opioid therapy without cancer. And And then those without cancer with long-term opioid therapy had a higher rates of having just musculoskeletal disorders or fibromyalgia compared to those with cancer. Those with cancer also, there were more people who were Black, and there were more people who were male with cancer compared to without. Overall, of the entire population of all the records, only about 13% of the entire population total actually had cancer. So that's something to note. And so you can see here, this is kind of how they found the intersection and then what the data points were in the range of what the doses of the prescribed opioids were and what seemed to happen over, as we said, like kind of those 16 90-day intervals. And then it was able to group them, and they found this separation of these 5 trajectories. And so this is looking at it smoothed out with cancer versus without cancer. And you'll see that the doses over time for those on very high doses, greater than 90 milligrams, stayed pretty stable, and then kind of went down but stayed high. Higher numbers of people, like 11% of those with cancer, were at that high dose or escalating doses, or the moderate dose and escalating doses of that. So it's a good, almost 25%, so almost a quarter of patients with cancer were on those high and moderate to high doses. And then again, noting that they didn't make a separation of how high above 100 milligrams a day. And compare that to those without cancer, and more people without cancer, greater than 50%, were at the lower dose range, or at the most were at moderate and stable dose. So that is a difference. And so now that they're looking at overdose events, and so this is looking at the cumulative incidence, or the number of new overdose events per person in the population over this time period. So this tells us an estimate of risk. And as you can see, the moderate and escalating dose, and then the high escalating doses for those with cancer, that cumulative incident, or that risk for overdose, increases. And increase pretty significantly here around that 6 interval. And that was consistent for those without cancer as well. So you can see that all of those trajectories seem to have the same pattern with both with cancer and without cancer. And then when you're just looking at the hazard ratio, or the probability of the overdose event compared to a control, you can't see it very well, but it's supposed to be bold. And I guess I should have circled this because you can't tell much difference of a bold. But those in bold are the ones that are statistically significant with a p-value less than 0.01. But you can see that the hazard ratio is, 2.5 times the control for those with high dose escalating or moderate dose escalating trajectory. And for those at moderate dose and stable, that's still almost 2 times the risk of an overdose event. And then the other one, especially, and not surprisingly, the patients with a diagnosis of opioid use disorder had almost an 8.5 times risk of an overdose event on long-term opioid therapy. And if they had a mental health disorder, 1.6, so almost 2 times the risk of overdose event. And then when we look at comorbidities, the renal insufficiency seemed to be, almost 3.5 times higher risk of having an overdose event. So what this study and the strengths of it are is that this study was able to separate the questions that we have of other studies that were mainly about survival studies and the rates of mortality in different patients, and metastatic cancer always being a confounder of, was that patient going to die of their metastatic cancer or related to harms from the opioids? And because it's not a survival study, they were able to pull out all of the comorbidities that could be risks, instead of other studies that usually looked at cause of death to see if there was a correlation. And so this is more accurate than previous studies. So at the end, the implications of this is that patients with cancer, same for patients without cancer, still have same risks of overdose. So they could still benefit from having the same process of informed consent, understanding this risk about long-term opioid prescribing, and that those of us, especially us in palliative and hospice care who prescribe opioids for cancer pain, should be receiving the same risk mitigation training and be offering that to our patients and families. Some limitations that I noticed, again, and I pointed out earlier, is just it didn't really go further for those patients on very high doses, greater than 100 milligrams morphine equivalent, which at least in my clinical experience is common for patients with severe cancer pain. And so I would want to know, like, is there another dose separation in that? And with that, I will pause and see, questions from the group. Whenever you're going through this, what did you see as limitations or takeaways from this article?
I was just happy to see this on paper. A lot of us here in this group have long known or seen this, and I was excited to see it in a paper format so that we could quote something.
Hey, Dr. Pasick. I was
Hi,
hoping
how
you
are
would
you?
chime in because you've been studying this for so long. What are your thoughts?
Well, I agree with what Monica just said. I mean, I spent much of my time, when I was practicing, I worked at least half the time always in cancer hospitals at Sloan with Kathy and Russ, and then also Kentucky and Vanderbilt. And of course, someone's famous when they only need a first name, like Kathy and Russ. It's like Cher and Bono. They don't need last names. I'm talking about Kathy Foley and Russ Portnoy. One of the things that's hard to capture in a study is it all sort of depends kind of on how you got there to the higher doses, right? And how fast, and how fast is one thing, but it's also like under what circumstances. Back in, when I was practicing many moons ago in the 90s and stuff, when I started, the cancer pain model in those days, everything was a reaction to undertreatment of cancer pain, and the people that were doing doing it and pushing the envelope on opioids in those days, it was very much in a tertiary care hospital like Sloan Kettering, people never did a risk assessment up front. And they only called people like me and people from psychiatry and other people in when the person got in trouble. And it was kind of easy to get in trouble if nobody assessed you for addiction or risk. And everybody was kind of on a self-titration model in those days. I mean, it was routine to say to a person, here's a whole bunch of Percocet, take 1 to 2 every 4 to 6, and take it liberally and stay on top of your pain and get in front of it. And then when you come back, we'll incorporate a whole bunch of that into your OxyContin, and then we'll continue to give you the rescues, and you keep on, lather, rinse, and repeat. You keep, escalating the dose in that way, but it was very much self-titration. And so for some people, that was a really good way to have a sense of control and get good pain management and do it, and of course they got away with murder in a tertiary care cancer center like that on the swanky Upper East Side of Manhattan, because a lot of people with really active addictions, first of all, cancer is still primarily a disease of 56, people 50 and up, and addictions, 85% of them are manifest by the age of 35. So if by the time you get your cancer diagnosis. And, if you make it to 70 and you've never had a problem, a self-titration model is probably appropriate, right? Because you're probably not going to get addicted de novo in that setting. But it would help if people asked the questions, understood all the risk factors, assessed the risk factors, and individually planned out people's cancer treatment instead of take as much as you need and continue to do so. And if you get into trouble, then we'll do something about it. So I very much agree with Monica that you would love everybody that writes an opioid for anybody not to take things for granted, to take it seriously. And don't put the person who's had a history of running into trouble with escalation of their opioids on a self-titration model, right? That's not appropriate for the people for whom it's not appropriate. And so a big part of, what's hard to capture is, did they get there because they were self-medicating their existential anxiety about cancer and started escalating their dose in that context, using it not strictly for pain like that, and then they got up to higher doses and got into trouble and had overdose events? Versus, they had a new metastasis and they had a rapid escalation of dose that maybe even came back down after, radiation therapy or something. So, I feel like I wish everybody knew how to do opioid risk assessments and plan an individualized treatment, regardless of whether you have cancer or not. Because at the end of the day, when you get out of the Sloan Ketterings of the world and you get out into the community, why would anybody be shocked that you'd see a lot of problematic opioid use in a group of people who have a disease, for a chunk of whom addiction is a risk factor for, right? Smoking, drinking, etc. And so, I feel like this is a very needed article, and it's really nice that somebody would come out and say, even if you're working in palliative care and oncology, you need to know opioid risk assessment. You need to know how to do it and plan the treatment. Plan the treatment accordingly.
Thank you, Dr. Pasick. And in the chat, Jack Kimball, if you could unmute yourself. Yeah, I'm trying to pull up page 3. Thanks for pointing out kind of the p-value on 0.82. I'm trying to find it. Is it in page 3 of the article, or are you talking about table 3? I'm just trying to follow with you.
Page
Thanks
3,
for
under the observed rates of overdose. I was just curious because the article makes logical sense, and I think echo what someone else said, that it seems to follow what happens in practice. I was just wondering if that I'm still new to all the analyzing articles, so I was wondering if that kind of detracts from the impact.
sorry, and anyone else please chime in too as well. I'm trying to find exactly that one on page 3, but the way when I was looking at they did try to highlight which were the things that seemed to be statistically significant or not. I don't know that at least when I was reading it, I think they did pay attention to what was not statistically significant while still giving us all the data that they got. I don't think it's enough for me to say I would just throw this out and say that this didn't, that they were just coming up with numbers. But sorry, I'm just trying to find, I'm looking at page 3.
Sorry, it was page 5 apparently.
Oh, okay.
I can't read numbers.
When you're saying you said it was the observed rate.
I don't have the article in front of me. Could it be that it's just not statistically significant, like the difference between the two, and that's what they're looking at, and the p-value is too low to show a significant difference, so it's actually showing that they're equal? That's what I'm guessing.
That was my understanding of it, because
Yeah.
you want a lower p-value to show significance, so it's showing that between the two groups there wasn't a difference in overdose, showing that the cancer patients were at similar risk of overdose as the non-cancer patients in that cohort.
Oh, okay. All right. Thank you so much.
Thank you for asking the question, because we're all learning, and this is a great environment for that.
Yeah, I love how you try to look at that and to say, is this is this good data or not, right? So thanks.
I'm interested to hear from the people who haven't been doing this for forever or for a long time. What have you got? Like, was this surprising to read or even to hear about if you didn't get the chance to read the full article? Is somebody willing to put themselves out there?
We have an oncology fellow on here to call her out, Abby Phelps.
Hey. I mean, I think this came up earlier today, even with patients.
Yeah.
I haven't had, I mean, I think that was the first time I've had a patient be concerned about an opioid, causing an early mortality, but usually I feel like they're pretty open to it, especially if they're in pain.
Abby, do you want to give a one-liner about that patient from this morning? Because I was thinking it's kind of interesting segue from this. Like that discussion we had about methadone.
Oh yeah, he was very concerned that methadone is only for drug addicts, and if he was on methadone, it would be considered a drug addict situation, and that he would be addicted to methadone, but was open to oxycodone.
And he has T-cell lymphoma, and he's on a ton of oxy to the point that I think he's going to get a ceiling effect, and he's having a ton of breakthrough with these terrible cutaneous lesions. And I just very gently brought up methadone just as like something to consider. Not that we were going to mess with anything, but just to talk about. And what I've run into a lot in the deep South is the immediate feeling that methadone is for heroin addiction, and I don't have a problem. And he said, I've been hearing about methadone since I was a young kid or something, and I definitely don't want that. But then when you look at his pain regimen right now, it looks like somebody who probably needs methadone. So I just thought it was interesting thinking about this paper.
No, that's a huge point, and it's there in the chat. And that's why we started this academic year talking about stigma, right? Because we're looking at these clinical, like for this month, articles that detail kind of clinical relevance and benefits and harms, but there's the human piece of it, of the stigma and the lived experience and what you're willing to do and what you're not willing to do just based on your belief system. And so there's a lot of stigma for people who know other people with substance use disorders and people who themselves are in recovery of substance use disorders. And then that feeds into even the medication treatments, right? Like buprenorphine and methadone, and feeling like I'm not going to be on that. And so hopefully when we're thinking about prescribing opioids, that we're being very clear about what the clinical indication is and not trying to undermine the risk of harm, and being very real and naming it, and trying not to do like, it's almost like a reverse that you'll see people try to say, oh no, but you've got cancer and so it doesn't really matter until it's a problem, and then it matters, and you just did this whole switch and then you've lost that therapeutic relationship. But being very aware of that stigma, and so knowing that, okay, this patient is a very highly opioid tolerant, which then I need to be able, as a clinician, to be able to define that clinically and separate that in my own mind of whatever stigma I might have about opioid use disorder. And also know that the patient has that stigma. So, I mean, that's kind of why we try to build on this. Is why we love having this monthly meeting. Yeah, it just speaks to that. Like they're more concerned, it sounds like, from the stigma than even what the risks are. That's what I'm hearing. Does anyone else have reactions to that patient about not wanting to be on methadone?
Yeah, I mean,
would
I
agree
had,
that. Go on.
no, you're fine. Yeah, I had a similar conversation with a young patient yesterday with similar concerns. I think with methadone, and I think it's really increasing with fentanyl as well, since there's such high illicit overdose rates. People are seeing it on the news, and are really afraid to start fentanyl recently too.
Yeah, I would say I'm just echoing everyone else here is like another young, like a recently graduated fellow that I've had this very similar experience where people are very hesitant to start methadone or like transitioning over to more of like a harm reduction opioid, just because of like the stigma that comes along with it. And I would say, like, to your point when you were asking earlier if this study was a surprise, I think that it makes sense. But I think just finishing fellowship and rotating with a bunch of different palliative docs, I think everyone is in this mindset that we want the most effective, lowest dose of opioids to prescribe to somebody to make sure that they're comfortable and we're addressing their pain. But I think in that sense, everyone had their own way of assessing for opioid use disorder or like opioid risk, where I don't think it's like commonplace for somebody to ask about personal history, family history, just do like a typical opioid risk assessment. And I think that goes in the point where we think that we're treating cancer related pain and that time might be limited. And so it isn't as important as if we were saying, we would be very, I would say judicious if we were prescribing to somebody that had non-cancer related pain.
Yeah, I mean, a comment I would have in terms of, things that may have surprised me from this article, or, I practice extensively outpatient palliative pain management oncology patients, so our ambulatory patient population. And, I hope this does spur more studies, because I almost would think that cancer patients may have a higher overdose risk. Obviously, it's a very understudied population, but from my own experience, I've seen GIGU patients on morphine have AKI and respond to Narcan in the field because they've accidentally overdosed on their morphine from accumulation. I've seen patients' kiddos get into their meds and overdose when they weren't stored appropriately. We have chemo brain. I've had a patient advanced cancer patient put their morphine ER in place of their IR, overdose, responded to Narcan, lived a whole nother year with quality of life with their advanced cancer. But you almost wonder if, because there's less risk mitigation strategies, as well as higher doses and appointment fatigue, infusion fatigue, chemo brain, et cetera, that these patients may even be at a higher risk.
Yeah, there's the articles from MD Anderson talking about non-medical opioid use, and that patients with cancer have a higher incidence of non-medical opioid use. So just knowing that, it makes me more concerned about that spectrum of opioid use. And I agree, there's not really the level of education that patients who have chronic pain or other pain syndromes get when they're looking at their opioids. Dr. Glass, I just wanted for the patient that you put in the chat with the Oxycontin and the oxycodone.
Yeah.
I had a few questions, and I think it would be good to look at the case a little bit further.